Okay, so good evening. My name is Russ Derry. I'm the Director of Education for Epilepsy Foundation of Michigan, and welcome to our Learn and Share conference call on autism and epilepsy. Our guest speaker is Dr. Elizabeth Leleszi, who is a pediatric neurologist at Beaumont Children's. So Dr. Leleszi, could you briefly introduce yourself, talk a bit about your clinical and research interests, and describe your experience with this topic?
Sure. Thank you very much again for having me. So yes, I'm Dr. Leleszi. I am a pediatric neurologist at Beaumont Children's. I am out of both the Royal Oak and Troy campus. I graduated from medical school at Wayne State University, did my pediatrics and child neurology residencies at Children's Hospital of Michigan and the DMC, and am board certified in child neurology with special qualification with child neurology, as well as headache medicine. And so I am a general neurologist. I do see a wide variety of different neurological conditions, and I have a special subspecialization in headache medicine, but I see a fair amount of children with both epilepsy, autism, both epilepsy and autism. So certainly I'm interested in the topic, and I think it's a fascinating and important point of discussion. So I thank you again for inviting me today.
Great, great, and thank you for sharing your time. So can you start by describing autism spectrum disorder and kind of the range of symptoms and behaviors that can be associated with it?
Sure. So autistic spectrum disorder is a biologically based neurodevelopmental disorder, and it is characterized by deficits in several features of communication, both socially as well as social interaction. Often found within the disorder, there will be repetitive behaviors, restriction of interest, and so these are features that we see. The disorder is diagnosed utilizing some clinical criteria found within what is called the Diagnostic and Statistical Manual, now in its 5th edition. And so clinically, we utilize this criteria to make the diagnosis. But of course, this is done with interview as well as examination with the child.
Okay. And it being a spectrum disorder, can you talk about kind of the range of symptoms and the range of severity and kind of the different ends of the spectrum?
Absolutely, and as you well describe, it is indeed a spectrum, and I think more recently we've understand this to be true. Before, autism was felt to be fairly restricted to those who are very impaired with regards to communication, social interaction, interest, and we now understand that autism can include those who don't actually have a severe difficulty with communication, but do have a variety of difficulties with interests being restricted and social interaction. And so you can see again, wide spectrum of those who are considered, severely impaired, moderately impaired, and mildly impaired with regards to these features. And I think that is important for us to recognize, both as physicians as well as other individuals in the community, teachers and educators, and families. So indeed it is quite broad. And it is important for primary care physicians as well to recognize that this is indeed spectrum, and that although somebody may not have a obvious severity in many features, that if there are concerns in these aspects of development, that they are brought to the attention of the physician and then subsequently referral as needed to whether that's developmental pediatrics, whether that's child neurology, whether that is child psychiatry as well.
Okay, great. So while the specific causes of autism are not well understood, several risk factors have been identified. So can you talk about these risk factors and other things we know or suspect about the etiology of autism?
Sure. So Indeed, there is no known specific reason for autism, but we do have certain risk factors that we've observed. We note that there are some individuals who have genetic changes or genetic disorders that are often found to have autism. And we also see certain genetic factors at play. We know there's an increase of autism in siblings. We see a high incidence with monozygotic twins, those who are consanguineous, family members within the same family. We see that. We do observe in research certain neurobiological factors. There's been found to, in some individuals with autism, have an increase in brain volume, so that's been of note. Advanced paternal and maternal age has been observed in children with autism, and there's likely to be some aspects of environmental or perinatal difficulty, essentially thought being that one has a, if you will, second hit, so that individual may have had an increased risk from a genetic perspective to have autistic disorder, and some environmental illness or factor then subsequently caused the illness or the problem to occur. And also certain teratogens, example would be Depakote in pregnancy has been shown to have a high incidence in autism. So there's a variety of risk factors that we see with that.
Right, right. So like autism, epilepsy has a wide range of possible causes. What are some of the possible underlying mechanisms that can contribute to both conditions and that might explain the association between them?
Sure. So I think that there's a multitude of findings we see from a neuropathological and neurological basis that certainly makes us pause to say, okay, there is some relationship between these disorders. Certainly epilepsy at many aspects is an imbalance between excitation and inhibition of these transmitters within the brain, and we see that in autism as well. We see problems with disruption in brain development that can be seen both in autism as well as in epilepsy. And there's some aspects of plasticity. So there's some abnormalities in how these connections are being made. We observe that certainly in epilepsy as well as autism. We can observe in some individuals that they have some malformations or changes in how simply the brain cortex was formed. Examples might be the cortical malformations, cortical dysplasias, example, little piece of gray matter getting stuck in the white matter in development, abnormalities in how the neurons are formed. And certainly we can see these issues both in epilepsy as well as autism. And so these aspects are, it's uncanny that many of these abnormalities are found in both types of disorders, and therefore it does make some sense that we do see a potential increase in incidence of epilepsy in those with autistic spectrum disorder.
Right. And presumably genetics can play a factor in both conditions as well.
Without a doubt, and certainly we see certain genetic conditions that have an increased incidence with autism. Many will point to conditions such as tuberous sclerosis complex. Some of the abnormalities on the 15th chromosome and others have an increased incidence, again, with regards to epilepsy of certain types. So indeed, genetic disorders are commonly seen in both autistic spectrum disorder as well as epileptic conditions.
Great. Okay. And what are our best estimates regarding the prevalence of autism spectrum disorder in people with epilepsy and vice versa?
Sure. So the statistics are not 100% clear with that, but
Right.
there is thought that approximately 30% of autistic people will have epilepsy. And that's, of course, fairly high. I kind of caution in that does not mean that if one is autistic, one is going to have epilepsy, but clearly there is that concern. And it tends to be that incidence increases a bit more if there is some intellectual impairment. And so, in those with intellectual impairment, that percentage goes up more. Again, it's intriguing about that because many of the things we just talked about with formation of the brain, synaptic connections, and whatnot, as a separate topic, are found in those individuals with intellectual disability. So, again, here we go. It's a similar nature. And I found another statistic, about 5% of kids with epilepsy may have autistic spectrum disorder, but again, these numbers are not firmly established. I think we can be fair to say about 20 to 30% of autistic people will have epilepsy.
Okay. And in terms of like kind of directionality of the association, I assume it can be it's kind of bidirectional, or sometimes epilepsy can come first and then the autism, or sometimes autism then the epilepsy, but it may have a kind of a shared underlying mechanism.
Sure. Certainly we see certain epileptic conditions, especially the catastrophic epilepsies of infancy, where the incidence of autism for those children is fairly high. And again, it leads us to the complexities of these interactions with formation of brain structure itself, synaptic connections, a host of things that hopefully within time we're going to understand in far more detail. Yes.
Right. Okay. Are there particular types of epilepsy that are more likely to be seen in people with autism? And as a whole, is epilepsy in people with autism more or less likely to be drug resistant?
There's not one specific epileptic syndrome per se for those with autistic spectrum disorder. Those with autistic spectrum disorder may have a variety of different seizures types, unfortunately, that can include the generalized epilepsies, such as the absence seizures, generalized tonic-clonic. This may also include the partial epilepsies. And so it's important for us to remain vigilant that there is not one, quote, type of seizure that a autistic individual may have. Certainly, when we go back to certain genetic syndromes, we do have to be watchful for certain seizure types. An example of that would be tuberous sclerosis complex, where we have concern regarding infantile spasms. Same thing may be true within Down syndrome. There may be an increased risk, and there is an increased risk of autism in Down syndrome as well. So we have to be vigilant for certain seizure types that are commonly seen within certain syndromes. But no, there's not one specific seizure pattern one is going to see with every, quote, autistic spectrum disorder individual. As far as for drug resistance, not necessarily. I think that the epilepsy in and of itself might be more to the point, Russ, as opposed to the autism itself. We will hopefully talk in the future about sensitivity of medication in those with autism. But I think more to the point, it's the epilepsy itself that may lend itself to challenge with drug resistance.
Okay. Now, I know Landau-Kleffner syndrome can involve language regression, as can autism. Is there any connection between those two, or are there ways to distinguish between those two?
Absolutely, and I think that's an important point for us to identify and try and sort out. Typically, those with Landau-Kleffner disorder will regress, if you will, later.
Okay.
With regards to speech and whatnot than autism. Autism regression, classically, although again there is a host of variation, is around 15 months. In Landau-Kleffner, that is later.
Okay.
The other pieces there, and to your point, from an EEG perspective, yes, there are significant differences that one can pick out. The business of electrical status epilepticus of sleep, where the abnormal electrical discharges occur with a very high percentage during slow wave sleep, is within classic for Landau-Kleffner. So there's some electrodiagnostic ways to look at it. Oftentimes it's the history. So listening to the family, again, very important. What have you observed with development? When did you start to see changes for that individual? What did you exactly see? What behaviors you're observing? Nothing replaces sitting down with a family and speaking with them face to face and seeing the young individual and deciding, okay, where do we go from here? I don't know if that helps with that answer.
No, that makes perfect sense here, right? So, and it leads right into my next question. So, sure. You mentioned diagnosis of autism involving primarily just patient history and talking with the family and using the DSM-5 as diagnostic criteria. Are there other diagnostic tests that may be involved when it's not entirely clear from those criteria?
I think what can be helpful is if you will, another set of eyeballs attached to another brain. So what often happens is, especially within the state of Michigan and other states as well, in order actually to receive services in the fact that insurance will pay for them, oftentimes that individual needs to go through what is called a comprehensive autism evaluation. And this is essentially a group effort where you have typically a psychologist, potentially a developmental pediatrician or pediatrician. There may be a social worker. There may be a variety of individuals at that session. And standardized testing of a certain nature, usually a couple of tests at least, including observation, are utilized in coming to a consensus conclusion. I think that the Beaumont Center for Human Development does an excellent job, the Hope Center, and certainly many others in assisting us. And as you point out, sometimes that diagnosis is not abundantly clear. So what I would say is that would be number one, is having a group evaluation, and we are lucky that there are many available. Unfortunately, for many families, the wait can be extensive, which in my mind is inexcusable. But that is, if you will, what it is. So there's that. As far as for other diagnostics, there's not one test. There's not one study in the blood. There's not one EEG. There's not one MRI that says you have autistic spectrum disorder.
Right.
This is a clinical diagnosis. And so I believe just, again, coming together, people working together and observing over time, not wasting time, but observing in time can lead us to the correct diagnosis.
Okay. So a large proportion of people with autism have EEG abnormalities. Can you talk about when EEG might be warranted for people with autism, and then some common EEG findings in those with autism and kind of what those findings might mean?
Sure. And, of course, this becomes tricky because children and adults, for that matter, who don't have autistic spectrum disorder may also have abnormal EEGs,
right,
may never have a seizure clinically or electrically. And so this, is, I think, is a topic that you can cast for many things. In relationship to autistic spectrum disorder, you're absolutely correct in that there is a proportion that may not have epilepsy, may not have clinical or electrographic seizures, but do have abnormalities. Classically, when would you obtain a study? Some of this is, well, gee, we're not sure if this child is having a seizure. You know, what are these episodes? Let's try to define them. Another may include this business of this electrical status epilepticus of sleep. Does that child, or adolescent for that matter, have evidence of that? That's a separate reason why one may get EEG. And then, you know, thirdly, there could be some other pieces. The individual may be ill or something along these lines. The abnormal electrical activity is usually a frontal, so towards the front portion of the brain, we'll see some abnormality. We do feel for some, and again, this lends itself to the burden during sleep of these electrical discharges, that they can cause difficulty with communication, with speech, even with behavior. And certainly when we find a high proportion of that in slow wave sleep, we would typically go after that. So not every autistic person or child will have abnormal EEG. We certainly see many who do have a completely normal recording every time you check or whatnot, but many do have some abnormality. The question is, what do you do with that? If one has some interictal, meaning in between any event concerning for seizure abnormality, but that proportion of abnormal activity is not high during slow wave sleep, and is not causing an electrographic seizure, meaning seizure that you don't recognize by just simply looking at that person clinically, but glance at the monitor and go, holy cats, this person's having a seizure, that individual likely does not require any specific treatment. Just to note that that person has an increased risk to have an epileptic seizure, to have a good discussion about some basic seizure precautions, which at the end of the day I find is common sense anyway for many people, and go from there. And then subsequently I would point out we often need more information, and that may include getting a longer study, whether that's a home EEG that one goes home with, or that one stays in our epilepsy monitoring unit here at Beaumont, where we do the study in-house. So your point is well taken. There are abnormalities we often see. It's clinically, i.e., what's the deal with for that child, we have to make those decisions.
Okay. So kind of you're treating the child and not the EEG, basically.
Correct. The vast majority we are treating that child, not the EEG. I think when you flip that coin is when you look at that EEG and during sleep it's extremely abnormal during slow wave, and you do a little bit more history and there actually are more issues developmentally than maybe at first glance, then you might have a different conversation, right?
Yeah.
But by and large, you're right. Treat that person, the person in front of you.
And in terms of the abnormalities during slow wave sleep, is that ESES specifically that you're referring
Correct.
to? And
Correct.
And can children with or people with autism have ESES but not have seizures?
Yes.
Okay.
There are some individuals who will have that pattern.
Mm-hmm.
They will never have a clinical seizure. They will never have an electrographic seizure, but they do have difficulty with impairment, with communication and whatnot. So I think this is a topic we are continuing to learn more about. We know that by simply treating ESES, say someone has autistic spectrum disorder, it should not be expected that that is going to, quote, cure the autism. Rather, we're looking to see, would by doing that improve things, help things for that individual? So that's an important distinction, too.
Okay.
I will say, however, that there is a significant proportion who have this ESES business who do have clinical seizures. So that's sort of the piece there, too, to keep in mind as well.
Okay. And for those who have ESES and autism but not epilepsy or not seizures, would the treatment for that be similar to the treatment for those with ESES in epilepsy? So like the Valium before bedtime, that sort of treatment plan?
It would be similar.
Okay.
I think it does get a bit trickier if one is having clinical seizures, with that in mind. So if that individual is having frequent seizures or is having some clinical events, that's where it can get a little bit more tricky. But the treatment is similar, and as you've defined, there are certain medications that can be helpful.
Okay, great. So what are some strategies, and again, for the situations in which EEG would be warranted, what are some strategies for maximizing cooperation and minimizing stress and discomfort for people with autism receiving an EEG?
Absolutely. I think that a lot of this is hats off to our EEG technologists as well as our child life specialists in this regard, because understandably so, a EEG in a individual who does not have autism can be a bit hairy at times, and then you add a sensory aspect to it, a new event that one has never undergone before or has infrequently, a new environment. There's often the flashing of lights, etc. So it really is the onus is on us to provide that level of comfort. I think that walking that individual through the process before the EEG starts can be helpful, and that can be helpful in making some story cards or some pictorials where we describe what's going to happen, what these EEG leads look like, where they're going to be placed on the head, what that paste kind of feels like, that there may be lights, that there may be a time where it's dark and we close our eyes, and that the leads will be eventually removed, using a washcloth, etc. So walking that individual through the process, whether you have autism or not, makes sense. So I think there's that. Also being cognizant to bring things that would make that individual more comfortable. If there's a specific item that individual finds as a comfort, bring it. In many situations, if the child has a tablet, there are some aspects where we have to turn that tablet off, but we may still be able to use it. Heck, we have videos on often while we do EEG. So there's that as well. And indeed, being very vocal, with your technologist, with your child life specialist, if they're there as well, and say, my son or daughter does better with this or is better with that. Depending on the technologist, they will be flexible. Could the child be in someone's lap? Could the child be seated in an upright chair? Would we feel more comfortable if we're reclining down? These are things, there's multiple ways to kind of get there, if you will, and we need to be flexible as well. So those are just some ideas, and I'm sure the group likely has some as well,
right,
to minimize some of that distress or discomfort during EEG testing.
Great. Yeah, and when we get to our discussion period, we can certainly, if anyone does have any suggestions there, please feel free to share. So, Okay, so in addition to the challenges of EEG, what are some other ways in which having autism can complicate the process of diagnosing epilepsy?
Sure. So communication certainly is a challenge for those with autistic spectrum disorder. Many are nonverbal. They may not be able to utilize other forms of communication, including sign language or picture exchange or the tablet with the essentially picture exchange in that higher tech form. And so we rely a lot on the history, what has been observed by the family or teachers. Is there video that has been taken? Nowadays, with our cell phones with video capability, although it's not completely easy, it is much easier to grab that phone and press the button. That can be quite helpful. Indeed, if we see that our behaviors that are repetitive but associated with an alteration of consciousness, meaning that individual is not really able to be redirected by verbal communication, calling that person's name, or touching them. So touching the side of their arm, picking up the child, redirecting them. If they're still not really able to communicate or at least acknowledge someone there, that is more concerning. Some of the other aspects that are more classic to what many individuals say, oh, this looks more like a seizure, of course, jerking of the face, the arm, the leg, stiffening of the limbs. And those things tend to be a bit more physically obvious. But I will say we get many concerns. Gee, I'm not sure. Is this a stereotypical behavior related to the child's autism, or is it a seizure? And to be frank, sometimes we're not sure. We need more information to define it. But to your point, it is challenging. It is challenging.
Right. And I'm imagining that MRI can pose similar challenges to EEG in terms of discomfort. Do you find that sedation is sometimes necessary, sometimes helps?
Well, I like to point out to families, I myself have not needed an MRI, quote, yet, but I know I would need sedation because I would wiggle, I would move. And yes, I think that the light sedation that we offer is an excellent way to ease the process. Again, it's hats off to the MRI technologists, the child life specialists, the RNs and whatnot, the individuals who identify that this certain population has these challenges. Walking, again, that individual through the process is absolutely advised. I do know that Beaumont does have a video clip through, I believe, YouTube in walking through an MRI. It is not necessarily with a autistic individual, but again, one could break down the story as well. We're going to drive to the hospital. We're going to get out of the car. We're going to go to this place. And this is what's going to happen next. I would also point out that parents and guardians feel free when you make those appointments to get an MRI, talk about these concerns. Oftentimes the anesthesiology group or the care group there are happy to look at what other accommodations might be put in place for that person. So speak up, and I encourage people to ask those questions as well.
Right, great. So can you talk about anti-seizure medications and how they can both negatively and positively affect symptoms associated with autism?
Sure. So, of course, this is the year 2019, and we have a host of seizure medications at our disposal. And so the question then becomes, again, what do we choose? Of note, I think this is a caveat for most individuals with autistic spectrum disorder, in that when one uses medication, those individuals tend to be quite sensitive. And why that is, no one's quite sure. But the idea is to, quote, start low and go slow. Now, that may not always be the luxury we have. Certainly in epilepsy, at times we truly need to get those seizures under control quickly for a variety of reasons, but it bears in mind that. As far as for some of the difficulties we can have, they mimic many of the things that those without autism may have, in that there are many seizure medications that may cause weight loss. There are many that may cause weight gain. Somnolence or sleepiness can be a problem. The need for drug monitoring, a blood poke, if you will, for many people with or without autism can be a challenge. And those are just a few of those aspects. The difficulty in expressing oneself if one is having symptoms related to the anticonvulsant without having the luxury of being able to speak, or perhaps being able to use a picture exchange or signing method can be a problem. So there's that. However, I think as a glass half full kind of person, there are other things we can look at as a potential positive. Certain anticonvulsants or seizure medicines can be somewhat helpful. Medicine I think about is Lamictal. Lamotrigine or Lamictal has been used with our psychiatry colleagues for mood stabilization for some time, and it is a quite effective anticonvulsant medication. So there is that. Also, by the very nature of using seizure medication to reduce seizure burden, people will often observe improvement from a behavioral perspective and whatnot, because we're not stuck in a fog having seizures, etc. So I think we need to look at both pieces, just like any medication. But those are some things that I think about for that. But again, we try to start low, we try and go slow, but sometimes you have to do what you have to do to make sure that that individual is safe.
Right. Okay. And what about other epilepsy treatments like surgery or neurostimulation devices and dietary therapies? Are any of these contraindicated in people with autism, or are there cases where they might have unique benefits?
I think certainly there's no specific contraindication to a certain ancillary epilepsy treatment. There may be with regards to that individual if they have some sort of a problem with metabolism that would make, for example, the ketogenic diet a problem, but that's very rare. By and large, devices such as the vagal nerve stimulator, epilepsy surgery, dietary modification, example, the modified Atkins diet, the ketogenic diet, can be helpful for those with autism. I think that the advantage to some of these interventions is that they are not sedating. Specifically, I think about the vagal nerve stimulator, where you do not get a sedation piece to it. So I think that there's an attractive aspect of this method of seizure control that for these individuals might be helpful. So I think that these things should be, quote, on the table for everyone, and I encourage families to speak to their neurologist or epileptologist regarding these interventions and bring up these things.
Mm-hmm. And I imagine, at least anecdotally, you've probably come across situations where, like a vagus nerve stimulator, the actual stimulation can cause a tingling sensation in the throat, which for someone
Sure.
who's sensitive to certain sensory input could be a problem for certain individuals, and similarly, people who have maybe some difficulties with, being picky eaters or that sort of thing
Sure.
could have difficulties with dietary therapies, but overall you haven't noticed any, major tendency for these not to work in
Correct.
people with autism.
And your point is well taken. I think that, again, that behooves the neurologist and the epileptologist managing that individual with, say, the VNS, to be cognizant of that and perhaps, again, start low and go slow.
Right.
Makes sense if one can. The other aspect with the diet, I personally have been amazed with the changes in just thinking outside the box with what we can do from a ketogenic diet perspective, from a modified Atkins diet perspective, especially for those with some taste or sensory or texture, whatnot, aversions. No one is going to pretend, oh, this is going to be easy, but I encourage families to think about it and not say, oh, that's never going to work, as it were.
Mm-hmm.
Our dietitians, our nutritionists are superstars in coming up with many different options.
Right.
And so that's something just of note, but your points are well taken, absolutely.
Okay, great. So there are dozens of behavioral treatments and interventions for children with autism. Can you talk about some of the most well-known and well-studied approaches?
Sure. Really, the therapy or the treatment, if you will, for autistic spectrum disorder is a therapy termed applied behavioral analysis. And essentially, this is a specialized therapy, ideally intensive therapy, often at home, as well as in center or school, that provides assistance with expansion of communication, expansion of interest, and expansion of some of these restrictive decreasing these restrictive behaviors. Generally, it takes time, certainly, for this behavioral therapy to work. Many parents and guardians comment to me that it takes, quote, 6 months, and then I, quote, started to see some changes. And indeed, for some, it's extremely effective. For others, it's less effective. But it is the only therapy, really, for autism. There are other ancillary points that can help with this, and that includes therapies such as occupational therapy. One of the aspects of occupational therapy is sensory integration therapy. And to go back to some of what we talked about a minute ago with the sensory defensiveness, aversion, this form of therapy can be extremely helpful in reducing the anxiety, the worry, and increasing the flexibility for many individuals by using a variety of modalities. Speech therapy in its traditional sense, modified for those with autistic spectrum disorder, is extremely helpful as well. And certainly support for the family in how to utilize these therapies at home, in the park, at the mall, at church, at synagogue, at school, wherever you're at, can also just amplify the results. So these are the things we typically see to be helpful for our families.
Right. Okay. So being a person with autism in a world designed for neurotypical people can cause a great deal of stress, and stress is one of the most common seizure triggers. So is there any evidence that some of the approaches you just discussed can help to reduce stress and thereby lower the risk of seizures in people with autism who also have epilepsy? And are there other strategies like relaxation techniques or things that you would recommend for people who have both conditions?
Without question, there are so many challenges in this regard. I think, of course, starting with the tenets of getting that individual into help and therapy with ABA, et cetera, that's one. Yes, you're absolutely right. Stress leads to decreased sleep, poor sleep, certainly a risk for seizure breakthrough, and multiple other pieces. I think that, again, starting with walking through social situations, where we're going, what to expect, utilizing tools. Example may be hearing noise reduction headphones, shades. Something of this nature may be helpful for others. Providing a item that is comforting to that individual can be helpful. Absolutely, relaxation techniques can be extremely effective. I think that for those who have the luxury in some ways of working with some of our child adolescent psychologists and coming up with some very personalized techniques, that can help as well. So I think that these other aspects make sense. I would also just add, if I may, I think it's important for us to work also with our child and adolescent psychiatrists too. Oftentimes these physicians can be very helpful to work with us because we know there are fair amounts of comorbidities with autism, not just epilepsy, but anxiety, obsessive compulsive disorder, depression, some explosive behaviors, attention deficit. So it's really important for us to work as a team. And I also encourage families to reach out to, if you will, the other half of neurology, the hard, difficult part of neurology, which is psychiatry.
Right, right. And you mentioned sleep. Are there other seizure triggers that people with autism may be particularly susceptible to, and what can be done to help minimize those triggers?
No, I think sleep is a major concern. That is often found to be disrupted in those with autistic spectrum disorder. I mean, that may be a whole separate topic of discussion. Tolerating medication. So there may be some other aspects medically for those individuals with autistic spectrum disorder, metabolism. So if you can't get your level where it needs to be, obviously that's a risk for seizure breakthrough. Certain epilepsies in and of itself may have trigger, as we are very well aware of the photosensitive epilepsies. That may be in of itself a problem. Those I think would be the major features. After that, I think it's not as much the autism, if you will, it's the epilepsy again.
Right.
It's the epilepsy in and of itself that is the major problem in trigger, et cetera.
And do you find that if sleep problems are a significant issue, that sleep specialists are familiar with both epilepsy and autism, or familiar enough with both conditions to be able to be a significant help?
Absolutely. Our sleep medicine specialists are invaluable. It's been an absolute honor and pleasure to work with individuals such as Dr. Trock and our newest addition to Beaumont Children's Pediatric Neurology, Dr. Bakdash, in the sleep disorders that we do see with those with autistic spectrum disorder. I would also tip my cap to the pediatric ear, nose, throat doctors, the ENTs, who also help us quite a bit, as well as the pulmonologists in this regard. So it goes back to the old term, it does take a team at times for us to provide the best possible care for that individual at any age. But yes, we find that that's been invaluable.
Right. So you mentioned psychiatrists and some of the comorbid psychiatric conditions that can be associated with autism, and so medications may be helpful in managing those conditions. Are there additional roles of medication in managing the symptoms of autism itself?
Sure. I mean, there can be some assistance, just like any individual, say, with, quote, normal growth and development, that, again, these comorbid conditions occur. There's no medicine for autism.
Right.
So certainly we need to point that right away. But say that individual does have inattention, lack of focus, they're unable to really focus on their therapies because they're so distracted or hyperactive. Well, that does nobody any good because we're not quite getting done what needs to be done. My first inclination would be to look at what behavioral interventions and accommodations we can do to help that individual stay focused. How can we minimize the distraction? How can we maximize the focus? And then medicine can be helpful as a tool in that regard. In addition, there are some individuals with autistic spectrum disorder who become quite irritable. And this has been well defined to be a problem that can result, again, not only in behaviors that may cause injury to the person, but others. And certainly that's no enjoyable feeling to have when one feels so, if you will, spinning out. So there are certain behavioral methods that can be quite helpful there. And yes, there are some medicines that can help that as well. Of course, we mentioned anxiety, high proportion of anxiety disorder within autistic spectrum disorder. And again, behavioral intervention first, but many of our medicines can provide assistance as well. And depression is also found in autistic spectrum disorder. So there are many tools for us. I think that the key is, the answer is never one, there's a, quote, pill that's going to, quote, fix everything. It takes a collaborative effort with the family, the patient, the neurologist, the pediatrician, the psychiatrist, in order to make those decisions. Again, start low, go slow.
Right, and presumably a good psychiatrist or a good neurologist will be completely comfortable managing the possible interactions between all of these different medications and the possible interactions with anti-seizure medications, the possible impact on seizure threshold and all of that.
Absolutely. I think that both ourselves in child neurology, epileptology, and child adolescent psychiatry, we both bring a little something to the table. I will often get questions from my psychiatry colleagues regarding seizure concern with many of the psychotropic medications. And at the same token, we will ask them what's next in order to assist this person. For many of the behavioral aspects, I will say this, that individual is often helped more with child adolescent psychiatry in that way. But we will work with everyone as a team to help everyone do better. So I think it's, again, one of those collaborative efforts.
Right. So we alluded to this a little earlier and talked about it a bit, but some behaviors associated with autism can be difficult to distinguish from seizures, and then some reactions to seizures can actually be mistaken for typical autism-related behaviors. So can you give a few examples of each and kind of talk about how caregivers can tell the difference?
Yeah, I think we need to sort of go back to first talking what many seizures may look like. And the caveat, of course, to that, as we all know, seizures may look like anything.
Right.
So all bets are off in some ways. But in general, there's some basic features that are more consistent with a seizure versus a behavior that is consistent within one's autistic spectrum disorder or otherwise, to be quite frank. Staring off into space or staring upwards or staring to the side in a very extreme glance to the side of one's visual field. Sometimes we will see these stereotypical, meaning they kind of look always the same all the time, behaviors in those with autistic spectrum disorder. People will often get concerned, is that a seizure? Is that a seizure? I think that the best way to try and investigate that first is to get that person's attention. So call their name first, call it twice. If they don't respond, my next suggestion is to touch that individual. Generally, touching the side of the arm will redirect that person. If it's a smaller child, picking the child up will often provide that stimulation. Now, if that individual still does not respond, it doesn't necessarily mean per se that's a seizure, but it does increase our concern with that. So even at school, this is a common observation. Well, we're not sure if this individual is having a seizure. We saw this. Oftentimes, we'll ask families to instruct the teachers to do the same. So call the name or touch the side of their arm. And again, if there's no, quote, response, that might lend it to more concerning for seizure. Some of the repetitive behaviors, such as rocking, back and forth, slapping of the hands, pacing back and forth, again, these are considered stereotypical motor movements often seen in autistic spectrum disorder. In that sense, again, try to get that individual's attention. Call their name. Touch the side of their arm. And if you're still not able to redirect that person, again, more concerning, but there's that. Clearly, if there is jerking of the face, the arm, the leg, that individual also is not responding to your stimulation, whatever that may be, stiffening of the arm, the leg, way more concerning for a potential seizure. But you're absolutely correct. There's some subtleties to this, and I will again admit, sometimes it's hard for us as neurologists and epileptologists to say, wow, that was a seizure. They can be very subtle, especially with some of the automatisms, such as smacking of the lips, some eye blinking, and whatnot. Again, that's where EEG comes into play, where we try and define these events, capture them, if you will, and look to say, okay, do we have seizure here or not? But you're absolutely correct. It can be challenging. And I encourage people, if possible, to utilize video. If these behaviors are repetitive, please bring it to the next appointment. I like to say that video revolutionized child neurology, because then we were able to look at these events. And I remember back in the day as a medical student, people would bring in huge video cameras and have to rewind it, and you'd look at it, and now it's on a phone. It's unbelievable.
Right.
But those would be some things just to mention.
Sure. So I would imagine, particularly in someone who's nonverbal and who's having a focal aware or simple partial seizure where they're experiencing some sort of internal symptom that's very upsetting, like fear can be a common symptom of a focal aware seizure, hallucinations sometimes, or tingling sensations, or all kinds of different things that could be upsetting, and that could lead the person to act out, if you will, but and that might just be assumed by someone who doesn't know they're having a seizure to be just a typical autistic behavior. But have you had any instances where you've been able to figure out that was going on?
I think that I have not seen as many of those characteristics, but they certainly can happen. I would point to sometimes we need longer monitoring, potentially without anticonvulsant medication or lowering the doses if that individual is on that medicine, or medicines rather, and to try again to capture what people are observing and seeing. Yes, I think that we need to stay vigilant for these things. If, again, these episodes are, they have their own MO, if you will. They're stereotypical in that they always look the same.
Right.
And That, of course, is hard because many behaviors in autistic spectrum disorder are stereotypical by their very nature. But if these specific events of fear or distress or whatnot look very similar in nature to each other, that is, of course, more of a concern. Right. And I would, vocalize that to say, hey, not sure, but this is what we're seeing. Here's a video example of it. What do you think, doc?
Sure.
And or practitioner or whomever, and we should further investigate. Absolutely.
And I would imagine the duration of the events probably can be helpful too, like focal aware seizures unlikely to last much longer than a minute, whereas some other behaviors might be longer. So
your point is well taken there as well. And then does that individual have some fatigue or somnolence that is uncharacteristic for that person's time of day or routine? That might be another clue as to this may be an issue for that individual. Absolutely.
Right, yeah, the postictal symptoms. That's a good point. Okay, well, one other thing I wanted to add or ask was adults with autism, I guess, or I should say adults who have not been diagnosed with autism, but maybe have been told by people that, I'm curious if you might have autism or be on the spectrum, are there, I guess, are adult neurologists familiar enough and other adult practitioners familiar enough with autism to be able to make a diagnosis in an adult when that diagnosis was missed in their earlier life?
Sure. Indeed, when you look at the clinical criteria, this diagnostic criteria can be applied later in life as well, oftentimes with, again, interviews. So that diagnosis can be established. They, quote, should be able to know and identify, diagnose an autistic spectrum disorder in an adult or, at late adolescence, whatnot. I think, again, as child neurologists, we are a bit more comfortable with it. I might point that individual more to a adult psychiatrist.
Okay.
Who might be able to provide a little bit more insight. I find that or a behavioral neurologist on the adult side might also be of some assistance there. So in that situation, Russ, I think those specialties or subspecialties, if you will, in neurology might be a little bit more helpful in saying, hey, I've been told this, I'm noticing this, what do you think? And that's where I would generally point them.
Okay, great. All right, so I think we will go ahead and open it up for questions. Okay, so before we open it up for questions, we're fortunate to have on the line with us Jill Mattson, who is with the Autism Alliance of Michigan. And Jill, I just wanted to give you an opportunity to share any thoughts that you had as a result of listening to the call so far, or any additional strategies or resources that you would like to share with the group.
Yeah, thanks so much for the opportunity. First, I just want to say, Dr. Leleszi, this was really amazing, very, very helpful. So thank you so much.
Thank you.
So as Russ had mentioned, I am currently the clinical specialist here at the Autism Alliance of Michigan. I am a pediatric nurse practitioner, and I actually worked a number of years in the neurology department at Children's Hospital of Michigan.
Yay.
And primarily worked with kiddos on the spectrum and other, developmental disabilities, with a few epilepsy kids thrown in there for good measure. But and then I'm no longer there, but I also am now working at the Center for Human Development with Dr. Hines. So just as an FYI, just kind of hoping to maybe provide some opportunity to do more kind of follow-up for kiddos on the spectrum and with developmental disabilities. Like a lot of, their work there is sort of focused around, with regard to autism, doing the diagnostic evals and just not having a lot of opportunity to do like some follow-up with families and see them in clinic. So I'm there one day a week doing that with her. And then I did just, have a couple thoughts and a couple questions too for Dr. Leleszi. One of the things that I would see not infrequently is when I was working with patients who had both epilepsy and autism, there were situations where, we would have kiddos who were on anti-epileptic medication that was being changed for whatever reason when they were being seen by the neurologist, or doses were being changed as well. And then interesting, I would sort of see some of these kids back for their sort of autism tests, and many of the parents would often report to me that they're seeing these significant behavior changes in their kiddos. And so, what we were finding, obviously, and I know Dr. Leleszi, you had mentioned that, is, obviously some of the anti-seizure meds we used for behavior purposes. And so sometimes, it was me sort of getting back in touch with the neurologist going, hey, I'm glad that they're like seizure free now, and like, they're like, going to try and start weaning off their seizure meds, but the Lamictal was really helping with behavior. And we sort of were getting that double bonus without really realizing it until we sort of started to try and take away some of those meds.
Yeah, no, absolutely.
Yeah, for sure.
I think for sure. And to that point, I think that's where, yes, reach out, families reach out, gee, we were noticing this actually was helpful. We didn't realize it was helpful. And then here we go, and we're seeing these challenges. Please pick up the phone. If it's please call, because we should be tailoring this as best that we can. In that regard, absolutely. Point extremely well taken. Yes, absolutely.
Yeah. And then I did, I have one question for you, and then I do have a few resources that I would be happy to share. But Dr. Leleszi, I just wondered what your thoughts were about genetic referral for kiddos who are being worked up for autism. I mean, it's always sort of, it's been a little controversial in terms of, it's sort of not in the standard of care that every kid being worked up for autism gets a genetic eval, but there are a lot of clinicians now, because of all of the genetic findings that we're seeing and correlations, that many of them do automatically refer. I just wondered what your thoughts were about that.
Absolutely. The more recent recommendations through Child Neurology Society, even through many of the individuals within the American Academy of Neurology, when we are seeing individuals with autistic spectrum disorder, we should ask why. Why does this individual have this challenge? Similar to epilepsy, why? And that can help us at times with how do we help that individual. We've alluded to at the earlier part the genetic aspect that is often seen with autistic spectrum disorder. Certainly our genetics colleagues have been instrumental in assisting us, and there are many of us who have special sub-interest in genetics. I think immediately of Dr. Danielle Nolan, who here at Beaumont Children's has a period of her time is devoted to genetics with epilepsy and other developmental disorders, including autistic spectrum disorder. It is my practice to investigate every child who comes to me with developmental concern as well as autistic spectrum disorder, to at least start with the basic genetic profiles. And indeed, there are now many panels that we have found to be of assistance in diagnosing individuals. I think certainly referral to genetics should be offered for any child with autistic spectrum disorder. So at this stage in the game, I think we've come away so much as should we really do it to we better do it. And although we can't necessarily say we're going to provide so much of an impact with this piece of knowledge, that may be true in 2019, but will that be true in 2025? I don't know.
Yeah.
So,
no, for sure. Yeah.
You know, so that's my take on it, and I think others, including Child Neurology Society, American Academy of Neurology, would, and I would even venture our psychiatry community, and would agree.
Yeah, for sure.
And am I correct in assuming? Am I correct in assuming that that the identification of genes related to autism is our knowledge of that is growing as rapidly as our knowledge of genes related to epilepsy?
I think that your statement is absolutely true. It's at an exponential pace.
Right.
And again, as neurologists, child neurologists, we try to keep up, if you will, with all of this. We need help, and that's where our genetics colleagues and our colleagues such as Dr. Nolan really come to the rescue and say, you know, what's next? What's next? And a lot of this is still in its infancy, but then again, once upon a time, understanding Fragile X was in its infancy.
Right.
Yeah.
So,
yeah.
You know.
And then I just wanted to share a couple quick resources with folks who may be listening. Yeah, so I know we were talking about sort of EEGs and kind of helping to prepare families and kiddos that are undergoing EEGs. You may have seen it, but they have a really, really nice toolkit on the Autism Speaks website. There's one for providers, and then there's one for parents on sort of getting an EEG and preparing for it. And they're free. You can download them, and I use them quite a bit, actually. They're really very nicely done, very easy to read and understand for the families. And then the last thing, just for those of you, if you're not familiar with our Navigator program here at the Autism Alliance, we are not a direct service provider, but we sort of try and help connect families throughout the lifespan to resources that they need. And although we are kind of autism driven, we certainly will work with, you know, individuals with other, you know, developmental disabilities as well. But we have a Navigator program that essentially is a free case management program where families, you can refer families to a Navigator. They're all masters prepared folks that have some background experience in autism and developmental disabilities. And they essentially will work with the family to get them connected with services with whatever they need, whether that's how do I find a diagnosis? We have, you know, myself, it's a clinical specialist. We have an insurance specialist who knows all the ins and outs of all the different insurances and where you need to go, who needs to go to an AAEC, who can just go to a psychologist and sort of can direct families that way. We also keep track of wait lists, where we can send families for evals and for services as well. And there is, we do have on our website, there is a Clinician Portal that you can just fill out as a physician. Sometimes I just even will have families, you know, just do it while you're in the room with families. It just takes 2 seconds to fill out with your contact info, the family's contact info, and what your concern is. It goes right to one of our navigators, and then one of our navigators will reach out to the family, and once we've made contact with the family, the referring clinician will get a notification from me saying, hey, we've made contact with your family and we're working with them. And we service folks throughout the entire state of Michigan, so this is for everyone throughout the entire state of Michigan. And then families can also go to our website. They can call us directly. They can email us their requests. And then I do also have, you know, obviously we have just some cards and some stuff for clinicians like in the office, or just to keep them if you just wanted to hand one to a family and say, hey, you know, looks like you could use some extra help, call a navigator. I can certainly maybe give my information to Russ and share that with you guys as well.
That would be fantastic. We would be very appreciative, and that sounds brilliant and very, very much needed. So, sure. Absolutely. Wow, what a great aspect with that. And our families, I can certainly say, and I do appreciate help in any and all aspects, I think that the Autism Alliance and certainly the Epilepsy Foundation are such a benefit and rock, as it were, in assisting these patients and families. So I thank you guys. That is fantastic.
Great.
Fantastic.
Yeah.
Great. Thanks so much, Jill. Other questions? We've got about 10 minutes or so, who else has some questions?
Yeah, I had a question in regards to the genetic aspect in relation to the autism side. Was I understanding correctly that there could be genetic abnormalities that are highly associated in having autism?
That is correct. There are certain genes that we are noting that have an increased incidence in autism. Certain genetic syndromes have an increased risk. However, I caution it does not absolutely mean that every individual with that syndrome will have autism. I point to tuberous sclerosis, which is a disorder that we often see with epilepsy. Those individuals, although there's an increased risk for them to have autistic spectrum disorder, many do not have that. But you're right, we are identifying several. And to be honest, I suspect there's much more. But again, here we are in the year 2019. We don't have the luxury of every single gene knowledge at this point, but it's exciting. It's a very exciting time in that way.
Are there a couple standout genes in particular that are known to be mutated and associated with autism diagnosis?
There are. What I would actually point to is some of the very subtle duplications of genetic material and deletions of genetic material that we are observing in individuals with autistic spectrum disorder. That is usually found through something called a chromosomal microarray. Another term for that, all in capitals, is SNP. Because, God forbid we don't put everything as a shorthand and in capitals and all that. But we are observing some subtle changes in several chromosomes. Off the top of my head, I can't quite come to let you know what those specifics are, but they are coming together with trends. So it is recommended, if you review again through the Child Neurology Society, American Academy of Neurology, it's recommended that those who have autism certainly have a chromosomal microarray. Consider testing for what's called Fragile X syndrome, and at times it still can be helpful to check what is called a karyotype, or your basic genetic profile. Over and above that, as I mentioned, there's several, if you will, panels, and these will look at specific genes that we have seen in certain disorders, including autistic spectrum disorder. So I would encourage you to speak to your pediatrician, your neurologist, your psychiatrist, all these, and look into that. But that's considered standard of care. Now, not every insurance company will do that. And certainly we have to be cautious with that. I personally don't believe in sticking anybody with a bill. So sometimes prior authorizations need to go through. We need to fight for this, et cetera, et cetera, et cetera. But if you look at the data, this is recommended. And I think it's the right thing to do.
Okay, great. And a gentleman had a question as well.
Yeah, hi. Is it Russ Derry?
Yeah. Yes.
This is Austin Ray. I talked to you about 3 years ago.
Okay, hi.
And I got diagnosed with epilepsy and in contact with Dr. Tyson Burkhart.
Okay, great. Did you have a question?
My question is my epilepsy, I started having seizures, and it has progressed, and it's been, I guess, kind of diagnosed as drug-resistant. And I had posed the question more recently as it's been progressing, as I was wondering I said it like this. I was wondering if I was becoming autistic, and I want to know what, like, if you could voice some thoughts on that, because I feel like I'm, and I actually don't feel like, I literally, I've been having more tonic-clonics, and I've gone to multiple hospitals now, and it, you know, very unique sensations, euphoria, and fractal images, and unique sensations, and which leads me to the question that my dad has, really, since the seizure, perhaps drug abuse in my 20s, and then having a seizure, then taking meds for it, and then using cannabis, would this escalate it?
I think to the first part of your question, can you develop autism later in life over time? You really cannot. Now, some of the features that you are observing can be consistent with people with autism. So I don't think that we can say, oh, well, you're observing these things, we just, you know, it can't be autism. I would encourage you to speak to your neurologist about this, and I would also encourage you, as we mentioned before, to talk with a psychiatrist about these feelings. It's valid that we need to look into them further because clearly they are bothersome and need to be evaluated further with that. And as far as for the epilepsy, clearly you're having significant challenges with control, and it is, I presume you're working very closely with your neurologist and hopefully an epileptologist in coming up with some solutions. Yeah. And
I've been at several hospitals, and Mid-Michigan Mental Health, I was there, and I was there for a while. I've been sober on alcohol for a couple of years now, and cannabis now for, what, Dad, 2 weeks? And thank you. And yeah, it really wasn't a problem. You know, I did it because of epilepsy and kind of research and stuff, and, you know, I was feeling, you know, some positive, but, you know, my dad was like, you know, it escalated, and I needed to be a place where I was safe, so, you know, I'm staying with him.
Sure. Support with the family is very important.
Yeah. So I think the key takeaway, though, is that you can't really develop autism as an adult. Now, as we mentioned earlier, there may be people who developed it as a child, but it was missed and it was never diagnosed. And that's where, you know, talking with a neurologist or possibly a
I have a reading disability, and I really didn't learn how to read until the second year of fourth grade. And I thought that was kind of a key factor. Yeah, and I had spinal meningitis when I was 10 months old.
Oh, dear. Oh, dear. So there's multitudes of factors here for you. And, again, as we've said before, it takes a team. And it sounds like you are reaching out. It sounds like you are utilizing these resources, including, more pointedly, the Epilepsy Foundation. And I encourage you to continue to do that in your journey.
Thank you.
And I wish you the best of luck. I congratulate you in your sobriety, and I think it's great. And say hi to Dad.
Could I ask one more question?
Sure.
I just want to make sure, because we're almost out of time, and I wanted to make sure that if there is someone else who had a question, we let them have a chance. Is that all right?
Of course, Russ.
Hi, I have one more.
Go ahead.
Hi, my name is Sharon. Fairly quick question. You mentioned about medication sensitivity. My son is 7. He has dual diagnosis of mixed epilepsy and autism. We have tried so far Keppra, Trileptal, and Vimpat. He has had mood and behavioral reactions to all three. Trileptal and Vimpat, he had poorer seizure control as well. So we're in the process of titrating up currently on Onfi, and obviously we're really hopeful that this will be a better fit for him. So I'm wondering, you mentioned Lamictal being generally a better fit for a lot of these kids, but I'm wondering if there's other medications or a class of medications, seizure meds usually, that are considered to be less likely to cause these behavioral side effects for them?
It's an excellent question. I will say this, there's not one specific group. There's not one specific class per se of the anticonvulsants or seizure medications that we think of, oh, hey, this is perfect for somebody with autistic spectrum disorder. And to your point also, although lamotrigine or Lamictal can be an excellent choice for some, for others, there may be an issue with that specific epilepsy where it actually would not be the best choice. So I think that, one has to paint that picture. Start low, go slow as much as one can. I think that's the absolute caveat here. And it sounds like that's that whomever you're working with, they're listening to you guys and saying, boy, this is just not working out. We need to think of something else. So I wish I could offer and say, hey, it's going to be drug this or intervention that. Really, it's not. But I would also point out that's true with epilepsy and those even without autistic spectrum disorder. So it's challenging. There's no question. But I think this point is exceedingly well taken. If something's not working, picking up the phone, calling, saying, listen, this is not working. Or, you know what, this is working. That's the other call that we like to get to figure out, okay, what's next on our roadmap to help this patient and family. So I certainly hope for the best for you guys and go from there. Thank you.
Thank you very much.
Great. So we are out of time. So if people do have any additional questions after the call, you could certainly email those to me, and I could do my best to answer those, or I could certainly ask people on our professional advisory committee if I need to, or Dr. Leleszi might be willing to share her thoughts on it too if you email me. So,
of course.
So thank you so much, Dr. Leleszi, for your time and covering this topic, which is obviously a very complex topic, and thank you again, Jill, for sharing all of those great resources. And thank you, everyone, for joining us. I just want to remind people, if you have further questions about this or other epilepsy-related topics, certainly visit our website at epilepsymichigan.org or give us a call at 1-800-377-6226. Our next Learn and Share conference call is on brain injury and epilepsy. That's going to be on August 7th from 6 o'clock to 7:30 p.m., and our guest speaker is Yanni Phillips, who's an epileptologist with Bronson Neuroscience Center. So thanks again, Dr. Leleszi. Thanks to our audience, and I hope everyone has a great summer.
Thank you. Enjoy the evening, everyone. Take care.
Thank you.
Bye-bye now.